After your patient has been diagnosed with CRPS, they could experience a number of different clinical manifestations. Some of them could include swelling and edema, pain, redness, muscle atrophy, dystrophy, weakness, and the inability to initiate movement. And the list goes on. The primary clinical feature that we are going to have to deal with is this pain sensation. So let's take a peek at a few different terms that you should know as it relates to CRPS and just pain in general. So we have this one term here called hyperalgesia. This is due to the peripheral nervous system having an exaggerated response to typically noxious stimulus. Okay, so if I were to take a sharp needle and prick your forearm with it, such as in a sensory test, you should experience some pain. However, somebody that has experienced hyperalgesia is going to feel an exaggerated pain response to that noxious stimulus. Allodynia is where we apply a non-noxious stimulus, such as a cotton swab. We're going to stroke the forearm with a cotton swab or perform some kind of light touch to the skin, and that sensation is perceived as noxious or painful. So I always like to give the example to my students. For somebody who's had a tattoo, everybody knows that a tattoo hurts a little bit. That's expected. But we wouldn't expect somebody to maybe jump up off the table in response to that known noxious stimulus. If they did, we would say maybe they have hyperalgesia. Allodynia, again, a light touch or non-noxious stimulus. If you put your shirt on and the silk material is causing pain, that's abnormal. That's an abnormal response to what we call a non-noxious stimulus. Again, the term allodynia here. So why does this happen? Well, we have what we call peripheral sensitization and central sensitization. Peripheral sensitization is basically the peripheral nerves become more sensitive. They are going to respond in a heightened manner to those noxious stimulus. It happens at the nerve ending. With central sensitization, we see a neuroplastic change in the spinal cord or the brain tissue. So for that patient who has allodynia, your brain is perceiving that non-noxious stimulus as something that is threatening to your body. And now we're going to get to the interventions to address the pain associated with CRPS. And the patient education, of course, as that is very important. I think as a clinician, it's important to tell our patients and to have them understand that pain does not equal tissue damage, and that the nervous system is being overprotective, but it's not broken. We can retrain it. We want to avoid immobilization and fear in regards to movement, and to tell them that gradual movement is safe and it's absolutely necessary. So I have a list of 3 evidence-based interventions that you can try with your patients who are experiencing pain with CRPS. The first one that I have written up here is what we call graded motor imagery, or GMI. This is where we get the patient to recognize that they still have a left and a right side. Typically, with CRPS and just pain in general, our body tries to forget the side that is experiencing the most amount of pain. And we want to practice mental imagery of safe movements to reorganize the central nervous system. And we can use that to our advantage, and we can use something called mirror therapy, which I'm going to show you at the very end of this video, just as a quick example. So graded motor imagery is a really good way for your patient to visualize safe movement patterns without being too aggressive on those tissues and causing pain. The second one is what we call desensitization techniques. So we can start with something like a silk cloth by stroking the skin, and then progressing that to something like a cotton ball, and then progressing that to something like a towel or a cloth, and then progressing that to something that is a little bit more abrasive, like Velcro. We're just trying to get the patient to move out of that state of allodynia where they're experiencing non-noxious stimulus as noxious or threatening. The last thing that we definitely want to do in physical therapy is promote therapeutic exercise and functional movement patterns. Again, the education is going to go a long way here. Your patients who are experiencing pain and have for years are going to be afraid of movement. We have to integrate all of these interventions in a way that is going to show them that movement is safe, it's not harmful, and it's actually beneficial for them. So stick around for a minute, and I'm going to show you an example of mirror therapy. Okay, so what I'm about to show you is part of that graded motor imagery that we talked about earlier in the interventions section. Specifically, this is mirror therapy. Remember, with CRPS, our nervous system, the peripheral nervous system, and the central nervous system is doing its best to ramp up those pain signals, and the nervous system is overexcited. So we may get pain whenever we're not really expecting it. Okay, we talked about hyperalgesia, the increase in what is normally noxious pain, but it's exaggerated, the pinprick sensation that we mentioned, and allodynia. So something that is non-noxious, such as a light stroking of the skin, is perceived by the patient as noxious. So we're trying to reverse those two main principles there. Okay, so what the patient is going to do with mirror therapy, remember, this is part of the mental imagery for initiating motor movement. So what I'm going to be doing is I have my left arm out in front of me, and I'm looking into the mirror. My right hand is the affected side, or at least we're going to say that is. So before I ask my patient to start moving, strengthening, stretching, all those kind of things, I'm going to try to trick the brain into thinking that I'm using my right side and I'm not experiencing any pain with that. We're going to trick the brain into moving away from that central sensitization and that peripheral sensitization. So this is what an early intervention would look like for your patients to try to help manage their pain. So I'm going to keep my right hand here just so you can see that I am not actually doing anything, but to the brain, using this mirror, it appears that I am actually moving my right hand. So I can have the patient open and close their fist. So obviously they're doing that with their left side, but the mirror makes it look as if that's my right hand doing the work. I can have them pronate and supinate their forearm. I can have them go into opposition, the first digit. I can do radial and ulnar deviation. I can do a lot of different things here, okay? So the entire time your patient is not using that involved side, but the brain is tricked into thinking that the affected side is moving without pain, okay? Then, as we progress, I'm going to switch this mirror a little bit here for you. As we progress through the treatment, now the patient can use their affected side, place it on the opposite side of the mirror, and then they can try to mimic what's happening with the uninvolved side. So this is an easy way to start initiating motor movements after we start to decrease that pain that's caused by peripheral sensitization or central sensitization.